Hi, my name is Dr. John Paul Gallardo. I'm in Miami, Florida. I'm a periodontist and implant dentist. Whenever I attend conferences and I meet up with colleagues all over the country, they always ask me how I was able to get the results that you see printed on the BioHorizons Alloderm brochure. The before and after patient is one of the cases that I did close to about 10 years ago. So this is the picture of the before. You can see very large amounts of resin composite on these roots to the point where there's really no attached gingiva left, and most of the root is actually completely out of the bone and exposed. So the general dentist that referred me the case really referred the case to me with the intention of replacing or removing both of these two teeth, number 23 and number 26, with dental implants. So I saw the case and I agreed. I said, okay, we can take these teeth out, but the first thing we have to do is regenerate soft tissue so that the implants can have soft tissue around them. So I decided to leave the teeth in place and then use Alloderm to regenerate the gingiva. So we did that using a vestibular extension technique, a lateral bridge flap, and the largest piece of Alloderm available. So it was placed in a non-trimmed position or condition. It was placed behind the existing gum tissue. I was able to get rid of the frenum pull by making a vestibular type of superficial incision and bringing all that tissue from the inner lip up to create a barrier or flap over the Alloderm material. And then that was all sutured in place. So I'm going to go through a few pictures, surgical pictures, to show you. This is the actual piece of Alloderm that was used. Again, I didn't trim it at all. I placed it whole and it was sutured in place. This is an example of what the roots look like after the composite was removed. Now, notice there's still some darkening on the root from decay, or mainly staining, because I remember cleaning off all of the soft portion of the tooth. But because we intended on removing these, I wasn't that worried about getting all of the darkness cleaned away. So that's what that looked like. And then this is a picture of the actual incision on the lip. So picture the fact that this whole area is the inner lip and the incision was made up here. And then all of this mucosa kind of like just slid back in a very tension-free manner. I connected this base incision to sulcular incisions here so that I can tuck my Alloderm material underneath that flap. This is what it looked like upon suturing. You can see the Alloderm right underneath the lip, the inner lip tissue. Sutures were used to basically almost take papilla and place them together. Join papilla here. Sutures were used to tack the base of the flap down, and you can actually see the mentalis muscle down here in this area here. This is what the area looked like after about a week of healing. So the moment I saw this, I knew that we were onto something and everything was going to work out. Nice vascularity, nice redness. Obviously what we don't want to see is white or gray after about a week. That designates that either the superficial flap has deteriorated or that the graft itself is not taking. So this is what the final result looks like. So here you can see a very, very thin scar line, almost non-detectable. Because it was such a superficial incision, the vestibule healed very quickly. Epithelial cells or gingival cells migrate across a surface at about 1 millimeter per day. So if you do the math, about 10 millimeters, 10 days, everything will be closed out without any major suturing at the base. So we did good. Patient 10 years later still has her teeth, didn't have to place dental implants, and we've been doing this on a routine basis. Not always such dramatic cases such as this, but very simple cases can be treated very effectively. So that's how we did it. If you have any other questions that I might be able to help you with, contact me. Again, John Paul Gallardo, D.D.S, 305-447-1447. Thank you.